Good afternoon, everyone. Welcome to APS Online Education webinar today. This webinar is APS White Paper Masterclass 2026 webinar, and the webinar topic is motion preservation in spine surgery. Where do we stand in 2026? I'm JB Park from Korea. It is my great honor to moderate this webinar today. For this webinar, we invited 5 distinguished speakers from India, Singapore, Indonesia, and Germany. So also, I'd like to thank Ajay Shetty and Niraj Vasavada for organizing this webinar for the participants. Today, we'll have five topics, and then for the motion preservation surgery, spine surgery. So each topic is 30 minutes lecture and 2 minutes discussion. So I'd like to invite the first speaker, Guna Kalachian from India. He will talk about agent segment disease after fusion, biology, biomechanics, or surgical consequences. Or Dr. Guna, please.
Thank you, dear Professor Park, and my dear mentors, Dr. Ajay sir, Dr. Neeraj sir, and distinguished faculty from around the globe, and the APSS team. So I would like to start the session. It is going to be an interesting session on motion preservation, and my topic is going to be what are the adverse effects of adjacent fusion, especially the adjacent segment degeneration. So this is going to be my topic of presentation. Professor, can you see my screen? Can you see my screen?
Yes, go ahead.
Yeah. So my topic is on adjacent segment disease. What is the biology, biomechanics, or whether it is a surgical consequence? This is a long-term dilemma still persisting, and this is going to be an interesting topic. So let me start my presentation with a very familiar patient whom all of us have encountered in our clinical practice. A patient presenting with a 2-level degenerative listhesis, undergoing fusion L4 to S1, and the patient is very happy, and he comes back to you at the follow-up. You do an MRI scan, and there is significant, very good bony fusion around the end plates, but still he has a back pain. But when you see the bigger picture, you see a disc popping out at the adjacent segment just above your fused levels. And this is quite common, and we have seen a lot of cases, such cases. So why does this happen? And the patient immediately asks the question, should I undergo a surgery again? I just back to my work after a long time, and should I undergo a surgery again? So this is adjacent segment degeneration, probably generated after a spinal fusion. So to know about adjacent segment degeneration, we need to understand the biomechanics of a lumbar motion segment. We all know the spinal column is a rigid 3-dimensional column supporting the visceral structures and our torso to stand as erect. And the motion actually happens at 3 different planes, including sagittal, coronal, and axial planes, translating into anterior and lateral shear forces and torsional movement around the axial plane. In our everyday activities like sitting, driving, standing, all these movements take place simultaneously, and it's not just only the shear force, it's a combination of either 2 or 3 movements that actually takes place. So every motion segment actually undergoes a lot of movement in all the 3 planes simultaneously. In spite of these, we tend to fuse our spinal segments. But why do we choose to even fuse our spinal segments considering the biomechanics? In fact, we orthopedicians treat degenerative joint pathologies like a knee joint or ankle joint and choose arthroplasty instead of a fusion procedure like total knee replacement, total hip arthroplasty. Whereas in spine, we tend to do otherwise, like we fuse the spinal segment and it has remained the gold standard. Why does this happen? Because there are a lot of motion segments in the spine, and hence, even if you fuse a motion segment, it can be easily compensated by the segments above and below the fused segment. So this is why we fuse the segments to even get a clinically acceptable outcome. But what changes after fusion? You choose to fuse a motion segment, and what changes after fusion? There is a lot of literature on this topic for several decades now, showing that when you fuse a segment, there is significant stress that's distributed in the adjacent segments. And this is one such cadaveric study where the fusion has been established across motion segments, and the inference was there is a significantly increased stress in the facet joints posteriorly in the unfused adjacent segments. Not just this, this is a finite element analysis where the authors have studied the effect of L4, L5 fusion, single level fusion on the disc above and disc below under various biomechanical loading conditions like static compression, flexion, and extension. And the results are quite interesting. If you see, once you fuse the L4-5 segment, there is stress distributed not only at the upper level but also at the lower level. But the stress in the upper level is significantly high, especially in the flexion. As you can see, it's about 42% stress in the adjacent level, and in extension, it is more in the level below the fusion segment. So not only the facets, the discs both above and below are subjected to significant stress once you fuse a segment. And there is a lot of studies on this topic where the surgeons have measured the intradiscal pressure, and the inferences are quite the same in all these studies. So coming to the blueprint of what happens exactly in adjacent segment degeneration. Once you do an orthodesis of a motion segment, you create a large lever arm, especially in a single level, double level, and we also tend to fuse long segments like 3, 4 levels, multi-levels. And this creates a large lever arm, a non-physiological center of motion. And hence force is the adjacent segment is distributed across multiple planes in our daily activities like forward bending, twisting, walking, etc. And this causes fractional increase in motion and instability, causing adjacent segment degeneration and accelerated wear of the adjacent segments. So this is what exactly happens once you fuse a segment. Coming to adjacent segment degeneration, it's a broad term including two different entities. The broad term is adjacent segment pathology, when the radiological findings because of this fusion, which get translated as either loss in disc height or disc space wedging or instability, is what we term as adjacent segment degeneration. Whereas a patient presenting clinically due to this degeneration, we call them as adjacent segment disease. As you can see, adjacent segment degeneration is a radiological finding measured in terms of radiological disc height collapse or disc space wedging, whereas adjacent segment disease is a clinical entity measured in terms of ODI and VAS scores. And there are various different definitions going around the literature for these two, where surgeons consider a disc height collapse more than 20% as adjacent segment degeneration and disc space wedging more than 5 degree as adjacent segment degeneration. Coming to the incidence of adjacent segment pathology, if you take the literature, it's wide and vast, varied literature evidence showing the incidence. As you can see, it ranges from 5% to almost 100%. Cause for this variability is the varied definitions across different studies, and also the overlap between adjacent segment degeneration, which is a radiological entity, and adjacent segment disease, which is a clinical entity itself. In spite of this wide variability, if you see the clinical symptomatic patients are almost 25 to 27%, and the overall revision rate is almost 2 to 10% every year. So this data suggests that even though adjacent segment pathology, which is wide variability in distribution, the clinically symptomatic patients undergoing revision surgery every year is relatively less. So in spite of this broad entity, do we have any specific pattern? How do they present radiologically? So for a long time now, since this topic was coined, there has not been any clear distinction or classification for adjacent segment pathologies until this recent classification by professors at Ganga Hospital recently evaluated their retrospective series and gave up this anatomical and pathological classification. Anatomically, as we have already seen, it can be either proximal or distal or combined. Proximal being the most common, almost 70% of your adjacent segments are going to be proximal segment degeneration. Coming to the pathological classification, it can either present out of the varied 6 types distinguished here. Like it can either present as either only disc prolapse or intradiscal vacuum where your disc height significantly collapses, followed by antrolisthesis or retrolisthesis. And one important point I have to say here is the retrolisthesis is relatively common of all the subtypes, followed by stenosis and combined types. The combined types includes a combination of all these 5 at varied levels. So this is one of the useful classification which we can apply in our day-to-day practice to classify our adjacent segment degeneration. Coming to the etiology, as you can see, it is a multifactorial etiology. I have broadly categorized it as patient factors and surgical factors. Patient factors include demographic, health status, which is osteoporotic, sarcopenia, etc., and radiological. And others include genetic makeup of the patient, smoking, etc. Surgical factors is listed below. This lecture itself is mainly focused on biomechanical factors, so I am not going to discuss much about the demographic or health status. All the highlighted biomechanical concepts are discussed in my subsequent slides. So coming to the facet trophism. As we all know, facets are the important stabilizers posteriorly, and they carry about 30% of the axial compressive load, and they form a 3-joint complex along with the disc. So facet joint orientation is very important, especially in a lumbar spine where the facets are sagittally oriented. When there is significant difference between this orientation of the facets, that alters the biomechanics and creates an elevated joint reaction forces leading to wear and tear of the joint cartilage. In the literature, the facet trophism is most of the studies described a 7-degree difference between the facets on either side, and the image on the right side shows the method of calculating the facet trophism. So this trophism creates an uneven load distribution, abnormal torsional loads, especially translating to the intervertebral discs, causing accelerated disc degeneration. In spite of this also causes a sagittally oriented facet, increasing the chances of translatory forces and antrolisthesis. Overall, this contributes to excessive wear tear of the disc, facets, and further resulting in instability, especially if you fuse your segments below and there is a lot of stress in the adjacent segment. Coming to the next topic, which is the pre-op sagittal alignment. This is a very important topic, especially in patients when we are dealing with adult spinal deformity. As we all know, the C7 plumb line usually passes through the posterior inferior part of the S1, and the plumb line passes through the lumbar discs, as the center of mass is equally distributed by the anterior and posterior moment arms. However, in patients with sagittal instability, the anterior moment arm significantly increases. The moment of the mass significantly increases, as it is depicted in this image. The left side arm is way away from the hip joints, whereas the posterior arm, which is mainly the erector spinae muscle, is very short. This creates a lot of stress on the adjacent segments after you fuse, and hence when you are dealing with adult spinal deformity, you have to be very careful, and preoperative planning is very important to put back this C7 plumb line back into its normal position. Studies have clearly shown that postoperatively, when you realign the patient to his original axis, the rate of adjacent segment degeneration is significantly less compared to patients who tend to have a positive sagittal imbalance. The next important topic is PILL concept, which we are all quite aware of. This was initially given by Schwab's, where he came out with a formula like the PI and LL should be within 10-degree range, and a lot of studies have been published since his description, and this is one important concept which I want to put forward. The PILL concept usually takes into account the regional lordosis, which is the lumbar lordosis from L1 to S1 end plate. However, the most important thing which we have to understand is the segmental lordosis, as most of our fusions are either single level or two level in a common day-to-day practice. In spite of giving importance to regional lordosis, it is also imperative to give importance to segmental lordosis, which translate into a regional lordosis. As you can see, this is a patient, schematic representation of a patient undergoing a single level fusion. If you fuse, this is a patient where the L45 segment has been fused in lordosis, and this has been translated into a global lordosis. On the other hand, if you fuse the segment in a relatively neutral position, causing a flat back of L45, your overall lordosis gets decreased, and this results in a hypolordotic lumbar spine. And lumbar spine fused in hypolordosis, there is a significant increase in shear forces of about 30% shown across various studies. So even in a single or double level fusion, it is highly essential to give respect to the segmental lordosis and fuse accordingly in that parameters. And this is one of the important finite element analysis which I would like to quote, in which the surgeons and researchers, they fuse at L4, L5 at various different lordotic angles, and the inference was when you progressively decrease the lordosis and increase the PILL mismatch, there is excessive stress on the adjacent segment. And even in single level fusion, that's why I want to stress, we usually consider this PILL mismatch in multi-level fusions and adult spinal deformities, but it is imperative to also consider it in single level fusions and give importance to segmental lordosis. At present, it's not just about PILL mismatch, but it is almost about age-adjusted proportional correction of lordosis. This concept came since Ruzzoli came out with this classification of the lumbar subtypes, where the lumbar curve can be classified based on the shape, based on the apex of the lordosis and lumbar distribution index, which is very, very important. Considering the significant lordosis is distributed in the distal lordotic segment from L4 to S1, and L1 to L3 is the proximal lordosis. So individualized distribution of lordosis is very crucial to avoid adjacent segment degeneration, and the apex of the lordosis and shape of the lordosis is as important as lumbar distribution index. Coming to the role of instrumentation, we all don't do a standalone fusion, and instrumentation is a significant part of our surgical armamentarium. So when we put our pedicle screws across motion segments, two things happens. It either It increases the stiffness of the construct, and that results in motion compensation by the adjacent segments, and also a dampening compensation. Motion compensation, as the term suggests, there is significant motion of the adjacent segments compensating the fused segment. Dampening compensation is that whenever day-to-day activities we are constantly subjecting our discs to loading of the spine happens, and when you fuse the motion segment, you take off the discs from its normal function, and the loading is significantly transferred to the adjacent segment, causing dampening compensation by the adjacent segment. This creates a lot of micro cracks in the disc, accelerated degeneration, causing increased wear and tear of the disc. Also, one important point is while putting your pedicle screw, your facet integrity is very important, especially with the MIS, advent of MIS, there are a lot of studies showing significant breach of the facet joint and facet violation, and this acts an important trigger factor for adjacent segment degeneration. Coming to the number of fusion segment, literature has a direct strong correlation. Once you increase the number of fusion segments, there is definitely a high chance of ASD, as you create a large lever arm and alter the instantaneous axis of rotation, causing accelerated wear and abnormal sagittal alignment. So overall, we have to be very cautious, not only in just fusing, but also be cautious in identifying the patient's sagittal profile and matching his sagittal profile to his original parameters. This is one such example. If you see, by every passing follow-up, the adjacent segment disease is usually seen as the follow-up increases. If you see at 1 month, the patient looks more or less good at the adjacent segment. But if you see, the L3-4 is almost a flat back, and L4-5 is relatively less lordosis compared to its original lordotic segment. If you see, as the year passed, by 2-year follow-up, there is significant collapse of the adjacent segment at L3-4 and vacuum sign with retrolisthesis, causing adjacent segment disease, and patient becomes symptomatic. So the 3 or more level fusions significantly increase your chances of adjacent segment degeneration compared to a single level fusion. This has been shown in a lot of literature. So coming to the next hot debate, is fusion the only cause? No. These are a few studies which have shown, in spite of doing only decompression and avoiding fusions, patients end up with the reoperations about 10% during their follow-up of 3 to 4 years. But as you can see, the studies which I have quoted here almost are 10 years difference, but still the question is the same. Is fusion the only cause? We are still under a lot of research is going on in this topic, and in spite of not fusing the motion segment, patient end up with ASD. So still the dilemma is the surgical intervention really a trigger factor for your ASD? To answer this, there are a lot of studies quoting that ASD is natural phenomenon. It is a natural process of Kirkcaldy-Willis degenerative cascade. So a surgical intervention has less to do. However, till date, we don't have any ideal studies comparing patients treated non-operatively or treated operatively to give us a clear-cut idea and conclusion on this topic. And this still remains unclear. But what we all know is that lumbar motion segments are dynamic in nature. See, when we stand, your motion segments are well lordotic, and when you're sitting relaxed after having a coffee in your couch, you see your motion segments become kyphotic. So with every day-to-day change of position and posture, your motion segments show a difference in their segmental lordosis. In spite of knowing this fact, we still tend to fuse the lumbar segments, which is exactly opposite of what is ideal for your lumbar motion. So coming to the topic per se, are motion preservation going to help? The aim of motion preservation is that it replicates this near normal biomechanics of lumbar flexion and extension in your day-to-day activities, restoring the function of the motion segments. There is a clear level 1 evidence to suggest the role of lumbar motion segment surgery. Example, total disc replacement in discogenic back pain without facetal arthritis patients. And this has been shown in various international publications, and a lot of research has been gone into this topic. And this is one such example. As you can see, after patient undergoing 2-level TDR, you can see in dynamic X-rays, there is significant motion at the lumbar segment shown by the anterior wedging of the prosthesis in flexion and opening out of the prosthesis in extension. And this is what creates a physiological load distribution. But studies have shown, long-term studies have shown, these patients also still end up in an adjacent segment degeneration, though the symptomatic ASD is relatively less compared to a fusion. So where do we exactly stand in motion preservation and ASD? These are two large-scale meta-analysis and systematic reviews published recently in our European spine journals, where they have taken into account the randomized control trials on this topic. And if you would be wondering what the conclusion will be, the conclusions of these studies are quite interesting. If you see, Even though there is level 1 evidence supporting the role of TDR in lumbar disc pathologies, the overall conclusion is considering the disadvantages may appear years after the initial procedure, spine surgeons should be very selective and cautious in selecting their cases for TDR and very cautious in doing it on a large scale, is what the conclusion of that study. And even this study concluded that even though it is more effective compared to a lumbar fusion as it is maintaining the biomechanics of the motion segment, vigorous evidence is still lacking and there is still a knowledge gap on the role of TDR in ASD. So what are the future prospects? There are clear evidence, as I have said, there are clear level 1 evidence for TDR in motion in LDD. However, in ASD it is still lacking, and a lot of genomic studies on disc degeneration and genetic backup is still underway to identify the high risk population of ASD and to help with genetic mapping. So the take home message is adjacent segment pathology is a complex interplay between various factors, both patient related surgical factors and biomechanical factors, and literature clearly suggests that it is not caused by only just by fusion. An aging spine with an altered biomechanics degenerated faster, and it is a 100% indication that it's going for a degeneration of the adjacent segment. Motion prevention strategies have been the talk of the town in the last few decades, and they help in restoring biomechanics of the lumbar spine, but there is a lack of clear one evidence and clarity on what it exactly happens to the adjacent segment degeneration. Thank you, Ronald. Thank you so much.
Yeah, thank you, Gunnar, for nice talk. Any questions from the participants? Any questions from the participants?
No, sir, we don't have any
Okay,
questions. Faculties
I
can ask
have
questions.
a question to Gunnar.
Yeah.
Yeah, if you decide the surgery for AS problem, what kind of surgical option do you choose? Yeah, do you choose extent of fusion or decompression alone or motion preserving TDR or interspeed device for the ASD problem? How to decide your surgical option for ASD surgery?
For which pathology, Professor?
Yeah, yeah. If you decide the surgery for ASD problem, what kind of surgical option do you choose? Extension, fusion, decompression alone, or motion preserving TDR or interspeed device?
So my decision in this surgeries is based on two aspects. One is clinical symptomatology. That is the prime concern for me. What the patient presents, what type of pain is it? It is either a discogenic back pain or instability pain is what I ask the patient first. Then I do a dynamic X-ray, just check for the motion instability at the motion segments. 3, I look for the MRI. I look for the degree of disc degeneration. I look for the status of the facets. I look whether the facet effusion is there. And based on all these 3 parameters, I hinder towards, and also the age of the patient and the nature of work. So based on all these 3, I decide my patients whether to go for a discectomy or a fusion. And I personally routinely don't do TDR on a large scale in my institution. So either to go with decompression only or fusion is based on all these 3.
Oh, yeah, time is limited, so thank you, Gunnar. And let's move on to the second topic. Yeah, second speaker is Junhao Tan from Singapore. He will talk about implant design and methodology in motion preservation, how engineering determines success. Dr. Junhao, please.
Thank you so much. Thank you, everyone, for your kind invitation to this talk. I'm Chun Hao from Singapore, from National University Hospital. And today we are going to change the topic a little bit to more basic science. I'm going to talk about implant design and methodology in disc arthroplasty. So just a quick word about history of this arthroplasty. It was first performed in the 1960s in Sweden by Dr. Fenstrom, who implanted a stainless steel ball-bearing prosthesis in both the cervical spine and the lumbar spine. However, it was reported to have a high rate of segmental hypermobility and subsidence. So while I was preparing for this talk, I actually found that as of 2026, there's actually 12 different types of FDA-approved cervical disc arthroplasty alone. Just cervical, there are already 12. So rather than going through one by one, slide by slide, about the huge differences between each of the disc arthroplasty options, I want to go through several concepts that I think they're very important to understand when it comes to about implant design and methodology for disc arthroplasty. So first of all, we'll talk about the native biomechanics of the cervical spine and the implant design and rationale to replicate the native biomechanical concepts. Thirdly, we'll talk about the bearing surfaces and the tribology and the fixation strategies of current arthroplasty options. So we first talk about the native biomechanical concepts of the cervical spine. Of course, this is non-exhaustive list, but I think that these three concepts must be very well understood before we go into arthroplasty. First of all, we talk about coupled motion, center of rotation, and finally kinematic signature. So first of all, what is coupled motion? We know that the functional spinal unit is the representative, of the smallest representative of the entire spine. So it consists of two vertebral bodies, of course, with the intervening intervertebral disc, as well as the posterior elements, the supraspinous ligament, as well as the interspinous ligament as well. So when we talk about the motion of the FSU, of the functional spinal unit in the cervical spine in particular, is actually coupled. What does that mean? It means that when there is an angular motion, it is often coupled together with a translational motion of one vertebrae relative to another. For example, if we are talking about C5-6 flexion, when there's a flexion movement arm, there's also a anterior translation of the C5 as relative to the C6. Similarly, if we are talking about right rotation of C5-6, there's also actually a coupled motion together with a right lateral bending in a coronal plane. So this was actually published in, there's a nice table published in 1994 in Spine, where we talk about, oh, these are 50 healthy, normal volunteers, and this is exactly what is the average range of motion at every single level from C2-3 all the way down to C6-7. But what we didn't understand back in 1994 is that the motion is coupled. So while there is, of course, a flexion range of motion and extension range of motion, there's also a anterior and posterior translation. Now, that is very important because that brings me to my next concept, which is the center of rotation. Because and that is because with the coupled motion occurring, the center of rotation actually does not remain stationary during the arc of motion. And the reason why, as you can see on the diagram on the right side, is that because as you flex, for example, there is an anterior translation of the center of motion, and hence you can see on this figure, they actually call it a ICR, the instantaneous center of rotation, because at every point in motion, the center of rotation changes. How much does it change? It actually depends on how much translation is associated with the flexion at that particular segment. The location of the COR varies. If you're talking about lower segments, for example, C5-6, C6-7, then you can see that it's actually almost at the superior end plate, just close to the superior end plate. However, as you go up to the upper segment, C3-4, C4-5, for example, the COR actually moves caudally. You can see at C3-4 and C4-5 is almost at the midpoint of the vertebral body. What does that mean when we are doing disc arthroplasty? We must be cognizant of the fact that if we are doing upper cervical spine arthroplasty, they actually experience a greater anterior translation for the same degree of flexion motion as compared to the lower cervical spine. And finally, the last biomechanical concept of the native cervical spine is kinematic signature, which essentially just means the movement versus the angular motion curve. Now you can see this y-axis is the angular motion per degree, and the x-axis is the applied moment to the cervical spine. It is a sigmoidal curve. In the middle, there is a region of a neutral zone whereby there is a high flexibility despite putting very little moment force. However, at the both ends in the flexion as well as the extension, there is high stiffness, and that of course is because of increasing resistance to of the disc, of the ligaments, of the facet capsules as well. So why is that important? Why are these three biomechanical concepts important before we do this arthroplasty? Because when we perform arthroplasty, we must be very cognizant of the fact that we must respect the native biomechanics. What is the ideal cervical disc arthroplasty? Of course, we want to preserve motion. We want to support the physiological load without causing pain to the patient. And in terms of material rise, which we'll discuss later, it must be biocompatible with a good life expectancy. Now, what happens if we don't respect the native biomechanics? We must remember that in the cervical spine, the facets are highly conforming, and hence, if you have a non-anatomic motion by the arthroplasty but not actually respecting the native segmental motion, that actually can result in progressive facet arthropathy and, of course, subsequently failure of the arthroplasty surgery. So how do we classify the many types of a cervical disc arthroplasty? These are the various ways we can talk about them. Firstly, we talk about the level of constraint. We can talk about the number of components inside the arthroplasty design, whether there's a mobile or non-mobile core. And of course, we have a special class called the viscoelastic core. Actually, as we go through the next few slides, you'll realize that actually they are all very much interlinked between one another. Why do I say that? First, we talk about a constraint ladder. There are two main types of constraint cervical disc arthroplasty options. We have the unconstrained and the semi-constrained. The definition of an unconstrained cervical disc arthroplasty actually means that the implant itself does not give any mechanical limitation to motion. Of course, having said that, if you put an unconstrained device into a real patient, eventually the motion will stop. But that is because of the patient's inherent tightness, be it the muscles, the ligaments, as well as the facet capsule. But by itself, the disc arthroplasty does not have a mechanical limit to excessive motion. What is the benefit of that? Of course, it increases mobility, but it may increase the risk of instability. And some of the examples in the current market will be, for example, the Bryant as well as the Mobi-C. Now, semi-constraint is much more common. Semi-constraint is defined as the physical motion being stopped outside of the normal physiologic range. And that can be because of the inherent stiffness of the material that is used to make the implant itself, or it can be because of a mechanical stop but that is accorded by the implant itself. So of course, it confers the benefits of unconstrained mobility within the normal physiological range, but yet at the same time confers greater stability. And of course, the examples are plenty. For example, the Proteus C, the PCM, the Secure C. So then we come to the topic of how many components does the disc arthroplasty have. If you are talking about a 3-component arthroplasty, that means that you have a mobile core, you have the superior end plate and an inferior end plate. And these are 3 different distinct components of the disc arthroplasty, which means you have 2 bearing surfaces. Number 1 is between the superior end plate and the core, and the second surface is the core and the inferior end plate. Now, why is that important? Because that also correspondingly gives you more degrees of freedom. It actually gives you 5 degrees of freedom. Why? Because you have 3 angular motions. You have flexion extension, lateral bending, as well as axial rotation. And yet at the same time, because of the mobile core, it allows for anterior translation as well as lateral translation. Now, what is the 6th degree of freedom that we are missing over here is the ability to compress over the along the superior and inferior axis of the disc, and that's assuming because that the core itself is non-compressible design. And some of the examples for a 3-component arthroplasty will be the simplified disc as well as the Mobi-C. When you talk about 2-component arthroplasty, you have only 1 bearing surface. So if I bring your attention to the figure on the right side, bottom right side, you can see that this Pro disc, there are only 2 components. There is a superior end plate and the inferior end plate together with the core itself. So that means that you have 1 bearing surface. And this essentially functions like a ball and socket joint. But the downside to that is that you have only 3 degrees of motion. You have flexion extension, lateral bending, as well as axial rotation. But technically, you do not have any translational motion between the 2 components. And many examples, but some of them are listed here, are the Proteus C, the DPU, as well as the PCM as well. And finally, you have this special class of a disc arthroplasty, which they call it a non-articulating prosthesis. I mean, it threw me off completely. But why is it considered to be a non-articulating prosthesis? Because the motion is actually generated by the core deformation itself, which means actually that the whole entire implant is one piece, but it consists of a non-articulating disc, but the core itself is able to be deformed. But that also means that the non-articulating prosthesis is theoretically the only prosthesis that allows for all 6 degrees of motion, which means that because of the compliant core, it allows for compression in the superior inferior axis. And some of the examples will be M6C and as well as the Bryant disc. So then we talk about the materials and the disc arthroplasty. Materials and disc arthroplasty, as we know, we have the bearing surface, very important because of, especially when we are talking about disc arthroplasty, we want motion, we want to allow for motion to exist, as well as the outer surface, which we essentially eventually need to allow for osseointegration for long-term fixation. We talk about bearing surfaces first. In fact, when I was preparing these slides, I found the concepts very much similar to the hip arthroplasty and the knee arthroplasty concepts. The ideal characteristics of a bearing surface, of course, you need to have high fatigue resistance, minimal friction, superior wear characteristics, and of course, you want to have minimum generation of wear debris. So very commonly, as I mentioned, to the hip arthroplasty options, you have metal on poly. Metal on poly most of the time would mean cobalt chromium on ultra high molecular weight polyethylene, or you have metal on metal, which is cobalt chromium on cobalt chromium. Other options are available as well. For example, pig on ceramic, and now not commonly used anymore, stainless steel. And when we talk about outer surface material, you have cobalt chromium. Cobalt chromium is one of the most commonly used metal that is in direct contact with the bone itself. Why? Because it's corrosion resistant, and also it reduces the generation of polyethylene wear debris. And hence, just now as we mentioned, poly on or when we talk about metal on poly articulation, the metal that is used is most commonly cobalt chromium. Titanium is good. Titanium offers a very good osseointegration profile because of the Young's modulus of titanium being very close to the cortical bone. However, the problem with that is that if the titanium is in direct contact with the polyethylene, there is an increased generation of the polyethylene wear debris. And hence, as we will show later, titanium is not commonly in contact with the core itself, with the polyethylene core, but it's often used as either a spray or just a titanium coating that's in direct contact with the cortical bone. So what are the failure mechanisms in the arthroplasty biomechanically? Number one, of course, we have mentioned before, generation of wear debris, and that actually can come on be it in a metal on poly design or a metal on metal design as well. And with the generation of wear debris because of the osteolyte, because of the inflammation, the macrophage induced cytokine formation, you also have osteolysis. But thankfully, so far in the literature, it appears to be rarer as compared to hip arthroplasty related osteolysis. However, the caveat to that is that we must remember that the hip arthroplasty literature has a much longer follow-up runway as compared to the disc arthroplasty, be it the cervical or the lumbar disc arthroplasty studies. And finally, when you talk about metal on metal, similarly to the hip as well, most of us will still remember the debacle that was caused by the debut synthes ASR hip, whereby the metal on metal arthroplasty has caused a huge amount of pseudotumor as well as aseptic lymphocytic vasculitis associated lesions, or LVAL. This is very interesting. This is published in Spine in 2011. This was a case series of 4 patients. 3 of them had cervical disc arthroplasty and 1 of them had lumbar disc arthroplasty, where they used metal on metal disc arthroplasty options, and the patient actually had histologically proven pseudotumor or LVAL lesions. And during the revision surgery, they actually had to take out the pseudotumor and revise it. So when we just a quick one on the fixation strategies. We know that there are primary fixations as well as secondary fixation. Primary fixations is achieved immediately after implantation of the implant itself. And one of the most important ones is actually press fit interference, which means that you choose an appropriately sized implant for that particular motion segment that you are replacing. Other options, for example, as you can see on the right side pictures, you have the Q option, which is the top right corner. You have the spike option, which is the middle, and you have the screw option, which is the lower one. There's several pros and cons exist for each. For example, the Q removes slightly more bone as compared to the spike option, and the screw, of course, gives you the strongest mechanical fixation, immediate primary fixation. Of course, having said that, it has been reported to be technically a little bit more demanding and challenging. But secondary fixation is very important because you need long-term osseointegration of your end plate, of your implant to the vertebral body end plate. And what kind of options do we have? We mentioned earlier just now, titanium has a very good profile in osseointegration because of the Young's modulus being very close to cortical bone, and hence we use it to spray over the end plate in the implant itself. People are also using hydroxyapatite coating, and now with porous 3D printed surfaces, we allow for interdigitation or trabecular bone formation into the porous surface. I apologize, I'm running out of time, but I just wanted to bring your attention to in terms of lumbar disc arthroplasty. Let me just talk about the quick differences between the cervical disc arthroplasty versus the lumbar arthroplasty. And I think that many huge number of differences, but I think that these three are the most important I find in terms of biomechanics between a cervical disc arthroplasty as well as a lumbar arthroplasty. In a cervical arthroplasty, we are dealing with lower axial loads that is experienced by the implant design. And the reason for that is very simple, because in a cervical arthroplasty, you're only dealing with the weight of the head, whereas, for example, in a lumbar arthroplasty, you're dealing with load that is far in excess of more than 50% of the patient's body weight. So much more compressive load in the lumbar arthroplasty. When you talk about facet contribution, there's actually less load sharing by the cervical facet joints. However, in the lumbar spine, there is actually a much more significant facet load transmission. And what does that mean? It means that in the lumbar spine, if you are using a over-constrained implant, that actually increases your facet overload. And the patient with no preoperative facet arthrosis may very well get a facet arthrosis postoperatively if the implant design does not respect the native biomechanics. So in summary, I just want to talk about what the several concepts we've spoken about. The native segmental motion, biomechanical principles. We talk about coupled motion, segment-specific center of rotation, and the kinematic signature. And what is the ideal implant kinematic design is to respect these native biomechanical principles. So there are things like level of constraint that we've spoken about, 1 versus 2 versus 3 component design, whether there is a fixed mobile core or not that gives you more degrees of freedom, whether the materials used are ideal for bearing surfaces to reduce complications and failure, and finally fixation strategies to allow for very early primary fixation, and finally secondary long-term osseointegration. And what we have not touched about but will be touched on by the next two speakers will be actually the very important surgical techniques, which will then also determine long-term longevity of the arthroplasty design. So I think that what I like about this is to understand we need to understand the native motion of the cervical spine and the lumbar spine before we implant artificial motion using a arthroplasty design. Thank you very much for your kind attention.
Oh yeah, thank you, Junao, for nice talk. And any questions from the audience?
No, Professor, we don't have any on chat box.
Okay, when we follow the cervical TDR patients, we can easily see the heterotopic ossification and then anterior bone loss of the fetal body. So what's your thought on etiology of these two findings and how to prevent HO
As a
formation and anterior body bone loss?
Yeah, so I think heterotopic ossification is one of the most well talked about complication of cervical, for example, cervical disc arthroplasty. I mean, there's several. I think we can split into things like surgical techniques, for example, minimizing roaring of the bony surfaces by using minimizing the use of a burr. And even if you use a burr, some people are routinely using bone wax to cover the implant itself, or rather to cover the bony surfaces to prevent any bone formation. But I also think that very importantly, you need to match as mentioned before, we need to match the design biomechanics of the arthroplasty design to the native biomechanics, because if done improperly, if the disc arthroplasty is implanted in the wrong fashion, then eventually the patient is not going to move very much anyway. And if the patient do not move very much, eventually that segment will fuse. So in a very well, in a good surgical technique utilized in a well, matched native biomechanical principles with allowing the motion to continuously movement, we can then reduce heterotopic ossification.
Professor
Thank you.
John, I
Yeah.
have a question. You see, there is recent surge in this viscoelastic core disc materials. What's your opinion on that?
Yeah. So I think that is something new on the blog. During my readings, I've read a little bit about it by using compliant cores. So it's quite exciting because they say that the viscoelastic compliant cores are actually the only theoretical design that can allow for all 6 degrees of freedom. So that means that it allows theoretically, it gives the best motion available to the patient as well. But I think the problem with the viscoelastic cores is that the long-term studies are now lacking. But theoretically and biomechanically, it definitely makes sense. So that's going to be quite something quite interesting to look out for.
Okay, yeah,
Thank
let's
you.
move on to the next topic. Yeah, Dr. Lin will present cervical disc research in 2026, indications, evidence, complication, reality. Dr. Lin, please. Okay, Dr. Lin?
Is he online, Candice, Dr. Lee?
Hello, hi. Let me just share the slides.
Yeah, please.
Okay. Okay. My everyone can see the slides already? Hello?
Yes, go ahead.
Okay,
Yes.
cool. All right. So good afternoon, everyone, and thanks to the organizers for the invitation. I'm Sushin, and today I'll be speaking about cervical disc replacement in 2026. This is not meant to be a marketing talk for arthroplasty, even though admittedly, I'm obsessed about motion preservation, specifically endoscopic spine surgery and disc arthroplasty, both cervical and lumbar. Instead, I want to give a balanced, pragmatic perspective from the viewpoint of a practicing spine surgeon dealing with real patients, real complications. And I've only got 15 minutes, so it's going to be a bit of a rush. I have no disclosures. So CDA has now matured significantly. We have over 2 decades of follow-up data, more implant options than ever, and much more surgical experience globally. The conversation is no longer about whether CDA works. We know it does work in selected patients. The real question today is who benefits the most, who should not receive it. Patients increasingly ask for motion-preserving solutions, and as spine surgeons, we need to understand both the science and the reality behind that demand. When we compare CDA and ACDF, the short-term clinical outcomes are actually very similar. Both operations are excellent at relieving arm pain and decompressing neural structures. The differentiator is motion preservation and potentially the reduction in adjacent segment stress. Multiple studies have shown lower adjacent segment reoperation rates with CDA. Although the absolute clinical difference is sometimes smaller than what early marketing suggested, but more importantly, CDA and ACDF fail differently. ACDF has issues like pseudoarthrosis and adjacent level overload, while CDA introduces complications such as heterotopic ossification, implant wear, and facet-mediated pain. So this is not about one operation replacing the other. It's about selecting the right tool for the right patients. In 2026, we now have multiple 10 to 15-year data sets. Overall, the evidence supports CDA as equivalent or superior to ACDF in selected patients for patient-reported outcomes and secondary surgery rates. Motion preservation generally remains durable. However, implant-specific outcomes vary significantly, and we should be careful about generalizing results from one prosthesis to another. We also need to remember that many ID trials enroll highly selected patients treated by expert surgeons under ideal conditions. Real-world practice is often much messier. Long-term follow-up tells us several important things. First, patients generally remain happy with their outcomes. Second, adjacent segment degeneration is reduced but not eliminated. Third, heterotopic ossification is common radiographically, but many patients remain asymptomatic. Finally, revision surgery remains relatively uncommon, but absolutely does occur, and when revisions are needed, they can be substantially more difficult than primary ACDF surgery. The ideal CDA patient remains relatively straightforward. Typically, this is a younger patient with 1 or 2 level disease, preserved motion, preserved facet joints, and soft disc pathology or foraminal stenosis. Disc height should still be reasonably maintained and sagittal alignment should be favorable. I personally think biologic age matters more than chronological age. A healthy, active 55-year-old may be a better arthroplasty candidate than a sedentary 40-year-old with diffuse degeneration and facet disease. So the usual advice is to avoid patients with instability more than 3 millimeters, fixed kyphosis, OPLL, severe spondylosis, osteoporosis. But the reality is many patients do not fit neatly into textbook indications, and this is where experience becomes critical. But what is all this advice based on? So there isn't one gold standard guideline that everyone agrees on, but NAS has some recommendations that are fairly similar in line with US FDA guidelines. They recommend for criteria 1, down here, radiculopathy from root compression in 1 to 2 levels from C3 to C7 that has either failed 6-week trial of non-surgical treatment, neurological deficit with weakness, or affecting function. Also recommended for criteria 2, myelopathy or myeloradiculopathy from central stenosis, again 1 to 2 levels from C3 to C7. And criteria 3, if multi-level, they recommend as part of a hybrid construct. They echo FDA not for 3 or more levels or neck pain, and maybe can use for adjacent segment disease with index fusion. Contraindications, same long list of contraindications echoing FDA points 1, points 4, 0.7, 0.11, quite logical, not an infection, allergy, inflammatory conditions, and malignancy. But taking a step back, the problem with sticking to FDA or society guidelines is that finding such patients are very far and few in between. The usual patients in my clinic, at least, hardly ever present clinically with such features, so we hardly be doing any prime indications. And more importantly, patients will not be getting a higher standard of care. They will be missing out on the benefits of motion preservation that they rightly deserve. So I work in NUHS, one of the 3 government healthcare clusters in Singapore, and we have a motion preserving minimally invasive spine unit, or MMSU, set up by Prof. Dennis Hay. I'm part of that unit, and I must credit him for some of the slides and cases being shared here. We believe in this arthroplasty for expanded indications, and it's summarized in a chapter in a recent AO publication. I'll go through some case examples in later slides. We believe ADR cases fall into 4 levels of difficulty. Level 1, prime indication, and the aim is to preserve inherent motion. Again, far and few cases, usually less than 2% of all cases that we see. Level 2 is the bulk of what we see and do, about 80% of cases. Extended indications where patients have the conditions mentioned on the previous slides, and we preserve motion where there's minimal or negligible native motion. Level 3, where patient has hypermobility, and we control motion leveraging on the unique properties of certain implants, specifically fixed core implants. Level 4 is the most technically demanding, where deformity is corrected and spinal rebalancing is performed. We believe all these features listed here are not contraindications to cervical ADR. We're saying good outcomes can still be had in patients with such features, but the caveat being that steps must be taken to identify potential pitfalls and mitigate them. So adjacent segment disease remains one of the major arguments for CDA. Biomechanically, the concept makes sense. So fusion increases stress transfer to neighboring levels. However, ASD is multifactorial. Age, genetics, baseline degeneration, sagittal alignment, smoking, and natural history all contribute. So CDA likely reduces biomechanical overload, but it does not magically stop degeneration. So I think the key message here is that motion preservation helps, but patient selection and overall spinal balance matter just as much. So we at MMSU believe motion preservation in adjacent segment degeneration and you can still have good outcomes if you go in knowing what to expect. So this is my patient with bilateral upper limb radiculopathy, forearm pain and numbness 5 years after a 2-level ACDF. You can see there's very minimal movement at C6, C7 or flexion extension views. MRI scan shows C6, C7 stenosis. So that's the axial cut on the right screen. CT showed decreased disc height on the sagittal cut with foraminal stenosis on the right side, right foramen, left foramen. And while BMD for this patient was normal, we go in expecting soft bone at C6, likely due to the stress shielding from the ACDF. Also, the presence of the plates make it difficult to position the CASPA pins to maintain distraction. And for this case, the M plates, as you see here, they were really flat and parallel. So for this case, do we do one more level of fusion and make the neck even stiffer, or can we preserve motion? So this is what I did. We went in, we moved the plate first. This is the position, fairly neutral. These are intraoperative C-arm images. And you can even see maybe there's a slight suggestion of a retrolisthesis at C6, C7 down here, over there. As expected, after release and distraction, there's restoration of height. And we use a ProDisc Nova with a keel for immediate stability and flat end plates to match the disc. And on the right is us making the keel cut. And that's the implant in. We weren't sure the fusion was solid, and we did try to test it, but erring on the side of the caution, plate was replaced. So post-op X-rays at 1 year show motion is preserved. Those are the flexion extension views. An intraoperative video of another patient of mine. He had previous laminoplasty 5 years prior, and he also had adjacent segment disease. So as you can see, a CDA was done. The laminoplasty is supposed to move, but clearly not as much as the artificial disc replacement. So hybrid surgery has become increasingly important in real-world cervical reconstruction. Many patients have mixed pathology, perhaps one level suitable for arthroplasty and another level with collapse or instability requiring fusion. Hybrid constructs allow us to preserve motion selectively while maintaining stability, where necessary. And I personally think this represents one of the most practical and rational uses of CDA today. This is a trauma case of mine done a few months ago. Patient's a 58-year-old lady. She tripped, she fell, and came in with central cord syndrome. MRI scan showed prevertebral hematoma, kyphosis, stenosis, mainly at C5, C6 with cord signal change. At C4-5, so you can see that C4-5 is cord signal change here, C5, C6 cord signal change here, and there's no major stenosis at 3, 4, and 4, 5. CT scans show teardrop fractures at C3 and C4 inferior end plates. And C5, C6, you can see the decreased disc height. You can see the stenosis of the bilateral foramen on the right side, on the left side. So in summary, the C3, 4, C4, 5 unstable. There is stenosis with cord signal change at C5, C6. And again, do we go anterior or posterior? Do we address the C3, 4, C4, 5 because it's unstable? And do we stage the C5, C6 for another day? So can we do a single stage? Do we need to stage this operation? How about the kyphosis? How do we address that? So there's a bunch of considerations there. This one I did hybrid. The fracture levels I decided to stabilize by fixing, and the C5, C6 stenotic level, I aim to preserve motion. So I started with C3, C4, the hardest to reach level, most cranial level first. I decompressed it, I put in the cage, and I fixed and held it with one screw first. Then I went on to address the C5, C6 level. I released, decompressed, and put in the ADR implant. Stress test you can see in the middle, extension and flexion seen. You can see the C4, 5, a little bit unstable. You can see some retrolisthesis down there. Then I finally addressed the 4, 5, and the final AP and lateral shots are there. And she's actually doing a lot better now. Power back to normal, yeah. So 2-level CDA is now mainstream in appropriate patients. 3-level CDA is still relatively niche and technically demanding. As levels increase, the importance of alignment, facet preservation, and implant positioning becomes magnified. So revision complexity also increases substantially, and the more motion segments you preserve, the more carefully you must think about long-term biomechanics. And just to show a few cases from our center, MMSU, facet arthrosis with instability still can preserve motion. Facet arthrosis with kyphosis still can preserve motion. Retrolisthesis, you can see there, with dynamic instability, still can preserve motion. And severe drop hit, in this case, a bit unique, severe drop hit, stiffness, you can see facet arthrosis, kyphosis, myelopathy. This patient was quite elderly, she had sarcopenia, osteopenia, but still can preserve motion. So technically, CDA rewards precision. Exposure must be perfectly midline. Decompression should be complete before implantation. Oversizing the implants can overload the facets, while undersizing risks instability and subsidence. End plate preservation is critical, and in my opinion, many CDA failures are actually technical failures rather than implant failures. The complication profile of CDA differs from ACDF. Heterotopic ossification is probably the most common long-term issue, and we also see things like implant migration, subsidence, persistent neck pain, and facet-mediated pain. Dysphagia still does occur because the approach is still the same anterior approach, and importantly, revision surgery after CDA can be significantly more difficult than revision after ACDF, especially once implants have been integrated. HO remains one of the most debated topics in disc arthroplasty, and the rates increase over time and the causes are multifactorial, like what Junhao said. So, there's excessive bony bleeding, implant malposition, over-dissection, and patient biology likely all contribute. The irony is that some patients eventually autofuse, but still remain clinically well. So the radiograph and the patient symptoms that they complain of, it doesn't always correlate. When CDA fails, the commonest reasons are poor indication selection, unrecognized facet disease, malposition, or progressive degeneration. Occasionally, we see instability, infection, or biomechanical mismatch. But most failures are not dramatic catastrophes. But more commonly, they present as persistent neck pain, recurrent radiculopathy, or progressive deformity over time. So onto specific issues like when the levels that need to be addressed are stiff. Above are common preoperative radiographs of 2 patients. So this is one patient, this is another patient. The disc degeneration is obvious, and on preoperative flexion and extension views, there is very minimal movement for the patient on the right at C5, C6 level. What exactly happens? So with disc degeneration, the annulus material stiffens, reduces disc flexibility under loading, and the decrease in disc height blocks movement, and facet engagement occurs earlier, limiting range of movement. The surrounding soft tissue also stiffens and contracts. So during the procedure, we need to restore disc height with a selected device and remobilize the stiff joints. Back to the case. If we notice that the segments being operated on are stiff and not moving pre-op or intra-op, we cannot reasonably expect much movement after putting in this arthroplasty device. So the first step is to anticipate it. These are our recommended pre-op investigations, not just erect AP lateral C-spine radiographs and MRI scans. Flexion extension views also to look for stiff joints and sometimes even instability. CT scans will reveal blocks to movement like syndesmophytes between the bodies, calcified discs, or rarely seen fused facet joints. And this helps us to plan our approach and decompression better. And if the level is not amenable to CDA, can consider fusion at that level. Bone density scans are also part of our workup as it gives us an idea of how much stress the end plates can take during distraction or how firm a hold the Caspar pins will have in the bone. Intra-op, we will have to remobilize the stiff segments. The sequence we recommend is first the annulus and uncovertebral joints using an ultracut, which is a sharp, flat corpse, as you can see here, shaped like a green ellipse in the diagram on the coronal view of the spine on the left. This is done from anterior to posterior, like in the diagram on the right, from superficial to deep as steps 1, then 2. Following that is a full discectomy, then finally dividing the PL posteriorly, giving a full 360 release to remobilize. Just like a knee joint, we can check the release is symmetrical by checking the tension on the intervertebral distractor and looking at the symmetry of the gaps between the vertebrae. During end plate preparation, the cartilaginous end plate should be adequately removed to ensure good osteointegration between bony end plate and implant. We recommend that care be taken to remove only the red areas. So for the Proteus C vivo, just the red areas down here. The blue areas are actually unnecessary. The anterior lip of the vertebrae, if excessively cleared, will only increase surface area for potential HO. The posterior blue edges are indeed tempting to clear out because it's directly in our line of vision, easily accessible, just like in the fusion procedure, but the fear is that of implant subsidence. Just like so, right here. If you see the posterior aspect of the C4 inferior end plate, there is no bone there. So implant subsidence would then lead to abnormal biomechanics and either implant loosening or and migration due to asymmetric stresses on the end plate. And if that progresses, it may lead to collapse with focal kyphosis and then failure of the CDA. At the middle of the end plates, again, care should be taken to not be too aggressive and risk end plate fracture and possible implant instability. But on the other end of the spectrum, during check intra-op views, if the implants do not sit properly, as we expect, we should have a high index of suspicion of incomplete cartilage clearance. So if you leave it, again, it may lead to poor osteointegration of the implant and subsequent migration or loosening and eventual failure. So to troubleshoot this, the first step will be to identify it, then remove the implant and do a check and proper end plate preparation. So in summary, proper pre-op planning is key for success and a smooth operation. Invariably, issues will arise and identification of the issues are crucial to allow early troubleshooting. While x-rays are nice, videos are clearer. This is a video taken during the operation just after the implants are inserted to show that the operated segment is remobilized. So revision strategies depend on the mode of failure. Some patients can undergo anterior explant infusion, other requires posterior decompression or stabilization. Complex deformity cases may need combined approaches, and one key principle is always planning for the bailout option before you start the revision. And these operations can escalate quite quickly. So there is now increasing evidence supporting CDA in selected myelopathy patients. In younger individuals with preserved alignment and mobile segments, arthroplasty can work very well. However, severe kyphosis, rigid deformity, or extensive OPL remain poor indications. And regardless of implant choice, the quality of decompression remains the most important factor. So last few slides, the reality in 2026 is that CDA has found its place, but it has not really replaced ACDF. In most centers, ACDF remains the gold standard for many cervical pathologies, but the best cervical surgeons today are not ideological, they're versatile. They understand motion preservation, but they also understand when fusion may be a better operation and should also consider level-specific solutions. So to conclude, cervical disc arthroplasty is an evidence-supported operation with excellent outcomes in selected patients. Patient selection remains everything. Hybrid constructs and multi-level use are expanding, but complications and revisions are real and should not be underestimated. Most importantly, balance and individualized decision-making is far more important than surgical ideology. And where all that starts is to have good training. That's my Kung Fu master and good friend, Dennis Hay. So we also, training also includes attending high quality meetings and conferences like this one, and also try to have good apprenticeship in the OT with meaningful hands-on. And that's Dennis and myself, mid-ADR surgery, showing our local and foreign friends exactly how we do it. Thank you very much for your attention. I'll be happy to take any questions and discuss your own experiences with CDA, hybrid surgery, and revision strategies. And a quick advertisement for Singapore Spine Society meeting, July 2026. Thank you.
Okay, thank you, Dr. Susan. And any questions from the audience? Yeah, Dr. Susan, you demonstrate the use of cervical disc arthroplasty for the ASF problem after fusion surgery. So how to choose fusion again or cervical TDR for the ASF problem after ACDF surgery?
Right.
You
So
can
I think,
apply same principle, okay?
Yeah, thank you for the question, Professor Park. So firstly, we always try, for us in our unit, we we love arthroplasty. We love to preserve motion, so we try our best to preserve motion, but where possible. So pre-op, like I said, we do need to do extensive preoperative investigations, both dynamic X-rays, CT scans to look for any bony defects, bone density scans to check the quality of the bone, and of course MRI scans to assess the location of the compression. So if it's possible to do this arthroplasty, we will try our best to do it, but we need to make sure that the facets are okay, the levels the bone surfaces are amenable to putting an implant in, and also above all, patient profile, make sure that they are compliant to physiotherapy and rehabilitation program.
Okay, yeah, thank you, Dr. Shushan. Nice talk. And yeah, let's move on to first topic. Dr. Asolapi Gatam from Indonesia, he will present lumbar disc replacement. Where does it truly stand in 2026? Dr. Asolapi, please.
Can you see my screen, bro?
Yes.
Yes, okay. So, good afternoon, everyone. So, my name is Hasan Gatam from Jakarta, Indonesia. So, thank you for the committee. Thank you, APSS, for inviting me in this webinar. So, my topic today is about the lumbar disc replacement. Where does it truly stand in 2026? So, first of all, why motion preservation? So we all know that this Rusuli classification is used as the base for fusion surgeries, especially in adult deformity. So whenever we want to do fusion, then this must be the base where we can get a good sagittal alignment in the patient. But we have to remember that this balance is evaluated while we stand. So we never think that what happened with our spine when we sit down. So basically, most our daily activities are sitting. So that's the true questions. Why we need to fuse our spine in a standing position while most our daily activities are in sitting. But if we look of the balance of our spine while we sit, so the balance changes. So it makes like a long C curve from the upper thoracic spine down to the lumbar spine. So that's what makes the fusion fail or makes some adjacent segment disease happening in the fusion after we fuse the spine. So then comes the lumbar disc replacement as one of the options other than the fusion for degenerative disc disease. So there is some hopes that we can preserve some motion, we can reduce the possibility of adjacent segment disease. And the true question is, which patient is good for motion preservations? What are the indications? And this procedure has already been around the world for from the 80s, but why the adoption rate is very low for this kind of lumbar disc replacement. Before moving on to the surgical technique and the indication, we have to understand the types of the implants that are available in the world now. So basically, there are three types of implants. So we have the three component prosthesis, the two component prosthesis, and one component prosthesis, or the elastic implants. So the different type of the prosthesis is used for having the 6-degree freedom of the motion of the lumbar spine itself. But the main problem is that up until now, there is no standard guidelines which to choose this type of implants. So we don't know whether we need to use a constraint implants or we need to use a less constraint or more constraints, which one we need to use more mobility or less mobility, ball and socket type or elastomeric. So basically there is no guidelines which to choose. And If we look at these two types of implants, because to be honest, I don't have any experience with other types of implants in the lumbar spine. I only have experience with the ball and socket types implant and elastic prosthesis. So basically, with the ball and socket types of implants, we try to change the biomechanics of the spine itself, because with the ball and socket implants, there are no compression movement on the spine itself. So whenever we put the ball and socket implants, so it tends to have more mobility at that segments, and it will increase the facet joints pressures at the back. But since there is more mobility on that segments, it will decrease the pressure on the adjacent pressure. But on the contrary, with the elastic prosthesis, the motion of the implant itself is not as much as the ball and socket type implants, and the range of motion is a bit decreased, is a bit stiffer compared with the ball and socket types implants. So it will eventually decrease the facet joint pressure and increase, but it increases the pressures a little bit on the adjacent level. So with these two types of implants, we can see that we can extend a little bit more of the indication with the elastic prosthesis. Whenever we have some kind of facet joint arthropathy, mild facet joint arthropathy that are contraindicated with the ball and socket type implants, then we can use an elastic prosthesis in preserving the motion segment of the spine itself. And some of the what happens after we put some lumbar disc replacement implants. So basically, if we look at this picture, this is the normal structures of our spine. The stability of our spine is maintained by the muscle, by the ligaments around the spine, like the ALL, PLL, the interspinous ligaments, the intertraversus ligaments, and also the facet capsule itself. So when we try to put some implants, we have to put it on the center of rotation of the spine itself, which is located on the 1/3 posterior of the lumbar spine. So we want so whenever we put the implants, we know we want to release the facet pressures that already happening because of the decrease of the disc height. And also, in order to achieve that, we need to cut the ALL, and also we need to cut the PLL, because these two ligaments is the most powerful ligaments that could increase or change the biomechanic of the spine itself. So we want to put the implants as posterior as possible, parallel to the posterior border of vertebral body. And on the AP direction, we need to put it right on the center. But this is what happened if we put the implants not at the back. So let's say we put the implants a little bit more toward the anterior part of the disc space, and we didn't cut the posterior longitudinal ligament, and it will increase the tension around the back of the spine itself. So it will increase the tension around the posterior longitudinal ligaments, increase the tension around the interspinous ligaments, and eventually it will increase the contact between the facet, the IAP and the ACP, which will make some lock facet possible. And with this kind of position of the implants, probably the segment of the lumbar spine will not moving. And also, if we put the implants not on the center from the anterior posterior direction, the vertebral body above or below might translate to the lateral side, which also might increase the facet pressure on one side. So positioning of the implants is very, very important. And the next thing is that the release is also very important during the surgeries. So we need to make sure that we open up this space using this distractor. So we need to make sure that the segment is on motion before we implanted an implant. So and also while trying to mobilize the segments, we need to make sure that there is no end-plate injuries during the procedures, because once there is an end-plate injuries, probably we cannot put some disc replacement in. So this is an example of my case. So this is a male, 42 years old, with radicular pain and back pains, normal neurology. So if you can see here on the MRI image, there is some degenerated disc at the level of APSS1 with some components of herniated disc. So the option is first we can do definitely discectomy, but the problem with discectomy is there's already big annular tear, lots of volume of herniated nucleus. There's already there. The problem with reherniation might happen, and back pains will aggravate in the future. So definitely we can do some fusion in this patient, but the problem is that it will lose some motion, sacrifice the back muscle, sacrifice the posterior ligamentous complex, which might lead to more adjacent segments in the future. And we can see that the L4-5 this has already some degenerative aspect as well. So in my opinion, probably these two is not a good options. So still young. So if we look at here at the paper from Professor Bertagnoli, so this is a prime indication for lumbar disc arthroplasty, since this is a single level. We have quite remaining this height. We can see here there is no facet joint osteoarthritis, intact posterior elements. So in the end, I put this from the anterior approach and put the disc replacement in. So what is the real indication for lumbar disc replacement? So basically, lots of literature said that degenerative discs that failed on conservative therapy. So this is the main indication for lumbar disc replacement. But turns out there are a lot of things that we need to address, we need to evaluate before doing lumbar disc replacement. But from all this consideration, there are some points that I think in my practice, we need to really evaluate more, especially osteoporosis, pars defect, and instability. So with osteoporosis is the biggest enemy, since we know that in the lumbar spine, the pressure is much more higher compared to the cervical spine and the anterior segment. So we need to have a good bone quality to prevent subsidence in the future. And if there is a pars defect, then if we want to do this replacement, if we want to push it, then we might need to also do some 360 degrees motion preservation, put some pedicle screws, and also some facet replacement on the back. Also with the unstable segment, we also might need to do facet replacement as well. But the other consideration that are not boxed in red, so probably this is more of a relative indication or contraindication of doing a lumbar disc replacement. So we can still debate on it whether it's possible or not. So if you look at this paper from Karen Butter Jens, so they try to make how to select a good patient for the total disc replacement. So here we have to evaluate the age. So they try to divide the type of the disc replacement that we want to put, and which patient is compatible for the type of the disc replacement. So basically, if we look here, so whenever we want to do a disc replacement in older patient, so we need to consider doing it with the viscoelastic disc. There's one compact one-piece viscoelastic disc because because possibility in that old age there must be some facet degeneration. And whenever there is some prior surgeries, especially at the back, when there is a facet resection, facet arthropathy, then also it is relatively contraindicated with the ball and socket implants. And the other things that we need to consider is whether there is some degenerative spondylolisthesis. We can also try to use the viscoelastic implants if there is some spondylolisthesis and also when there is a facet arthritis. So there are lots of things that we need to consider before putting on a disc in. And regarding the facet joints, I think Guna has already mentioned that when there is a facet tropism, there might be some increase in the possibilities of facet degeneration. So if you look at this paper, that the rate of facet degeneration is around 15 to 20%. But we have to remember that when we put the disc replacement in, it preserves the sagittal balance and it has more protective effect on the spine. So basically, even though there is some facet tropism, we still can put lumbar disc replacement in. And in my practice, even though there is some facet degeneration in the image and the CT scans or on the X-rays, sometimes the patient has no symptoms. So the main question is whether you want to consider disc replacement in this kind of problem, or you want to stick with fusion when there is a facet joint arthritis. So basically, since we put a disc replacement from the front, then we can protect the posterior muscle, and also disc replacement preserve some motion if not all the motion is preserved. This is just a reminder that whenever we put a fusion, this is my very own patient. So from single level spondylolisthesis, adjacent segment disease, and then extension of fusion above and below, and then another failure, another extension of fusion, and then another failure. So this is what happened with fusion. So we are against the law of nature when we put the patients on fusion. So as I mentioned earlier, that quality of the bone is very, very important. And up until now, there is no literature that could predict the subsidence of the lumbar disc replacement after reporting in. So there is some literature that doing some loading on cadaveric studies, loading on the vertebral body around 2,500 Newton. So we want to put the implants on the apophyseal ring of the vertebrae. So this is the most ideal implants because the apophyseal ring is the strongest part of the bone that can withstand a very high compressive load. But most of the implants that we could fit in is not really on the apophyseal ring, but it's more on the center of the vertebral body. And sometimes even it's too small, located on the center of the vertebral body. So almost no available implants that can sit on the apophyseal ring. So according to this paper, so we need to evaluate the bone mineral density, whether the bone mineral density is normal or not. So basically, whenever when we have more osteoporosis patient, we need to put much bigger implants to prevent subsidence of the spine. So basically, on very, very small implants, we'll have a big implant forces and there's some risk of subsidence. So if we have a good bones that we might need less contact surface area in order to reduce the possibility of subsidence. So this is just an example. Patient, male, 62 years old, with chronic low back pain. You can see on the X-rays, there's a vacuum disc on the L5+1 and L4-5. And then I put a disc replacement in. And you can see here at the level of L5+1, when I try to mobilize it, there is some subsidence occur directly in TROP. And then after 3 months, there is some definitely subsidence. So
Dr. Asram, time is limited, so I'd like ask you to conclude your talk because it's long.
Okay. Yep. So this is what happened. So there's some osteoporosis, small implants, and also some age. And well, definitely we can put some disc replacement in a very old patient. So this is one of the example. So, and also the implants is moving. Okay, so, and also if we put the implants with this some kind of technical error, the spine is still moving and there is still no clinical symptoms. So the question is whether should we be afraid of doing a disc replacement. So in conclusion, still lumbar disc replacement is one of the options for degenerative disc management. There is still some controversies exist, but preserving some motion definitely has some protective effect, even though fusion is still needed in some patients. An indication for disc replacers needed to be selected carefully. Thank you, Prof.
Thank you, Dr. Asraf. We are behind the schedule, so let's move on to final talk. Final speaker is Dr. Trubis from Germany. He will talk about vertebral tethering, AIS, motion preservation deformity, promise, and pitfalls. Dr. Trubis, please.
Hi everyone, it's a great honor to present here and to be with you. My name is Per Trobisch and I'm from Germany. I want to share my experience on vertebral body tethering and what has happened the past 15 years and where we might be going. To discuss the future, we have to discuss the present situation, right? And this is what we do right now for a young kid with a big scoliosis of 70 degrees. This is actually a very old case. And the patient was fused down to L2. When we fuse patients to L2, I tell my patient, you can actually still have a pretty good motion and you might still be able to touch your feet and you can still participate in sports. And as you can see here, this girl, 4 years after surgery, has a pretty good motion. She doesn't really have great motion at the thoracolumbar junction, but at least in the lower lumbar spine, it's pretty good. So why do we need to change anything? And there's a reason for that, because we do have long-term studies that show a pretty high risk of degeneration below the fusion, so adjacent segment degeneration. And it can be as high as 68% for patients who have a fusion down to L2. So 2 out of 3 patients after 10 years have degenerative changes in the lumbar spine. If you fuse them to L2, it's still 1 out of 2 patients. So every other patient has degenerative changes in the lower lumbar spine. And why is that? It's because there's a compensatory hyperflexibility below the fusion, and that has been well analyzed and presented by Michel Marx from the Harm study groups. There's an increase of motion from L4 to S1 up to 50%. So now you can say, well, that's actually a good thing because patients stay flexible, but you can also say it's a bad thing because it increases the risk for adjacent degeneration. So wouldn't it be nice to have something to fix scoliosis but still be flexible, like this tether, which is a screw cord combination, which is attached to the spine from the side and allows motion. And it's nothing new. It has been well investigated by basic research studies. Here's one animal study from Peter Newton that shows tether is effective. And then there was a case report, which is actually quite long ago, it's 15 years ago, and it presented 5-year outcome for a patient who had vertebral body tethering. But it really started in 2011 at Shriners Hospital for Children in Philadelphia, and I had a chance to do my fellowship there, and I participated in the first case they actually did. And the first case showed a pretty good outcome after 2 years with a straight spine and good growth modulation. So a few years later, I think it was in 2014 or 15, so a little bit more than 10 years ago, the Shriners team from Philadelphia, they published their their initial analysis and initial experience from vertebral body tethering, and it was pretty promising. Low complication rate, they proved effectiveness of growth modulation by vertebral body tethering, so everything looked pretty good at that time. But then between 2015 and 2018, there was no publication. But why is that? There's a reason for that. The Shriners data was pretty promising, so that the FDA approved for, collecting data. And then there was this FDA study, but they also asked the surgeons not to publish any data before it was officially analyzed by the FDA. So not to publish off-label product surgery. So that's why there was nothing for the next few years. But then FDA approval came in 2019. They checked the data, saw it's effective, and now we can approve the system for the US market. In Europe, it was approved a little bit earlier because we have different regulations. So now we come to this decade. So with 2020 until today. So what happened over the past couple of years, especially after most of the US surgeons were able to do VBT because they had FDA approval. So there are far over 100 studies that have been published. Most of them are on Lenki 1A and Lenki 1B curves, and they all show very reproducible results. The estimated correction is approximately 50%. So it's a little bit inferior to fusion. There's a high breakage rate, up to 20%, but breakage rate doesn't always mean complication rate. It's just an observation. But tether breakage can actually lead to a loss of correction. And there are revision rates that are actually decreasing down to 0%, but it's probably somewhere around 10%. The question really is Lenki 1A curve, is that really the best scoliosis to have VBT? Because most studies are on Lenki 1 curves. There's an ongoing discussion, when is the best timing to do VBT? What is the best operative technique and surgical technique? How do we handle revision surgery? And what is the value of motion? How important is motion really, especially in thoracic spine? So there's a current trend. Many surgeons went down from the thoracic spine to the thoracolumbar spine because many surgeons believe that motion in the lumbar spine is much more important than motion in the thoracic spine. And there's another trend that's actually combining VBT with fusion strategies. So let's focus on the lumbar spine. Why do we need something for the lumbar spine? Because if we don't treat lumbar surgery, lumbar scoliosis, it can actually result in pretty bad outcome. But what we have right now is not good. We see adjacent segment degeneration after segmental instrumentation, posterior, anterior. I see adult patients in my practice every day, and many of them have had surgery 20 or 30 years ago. Many of them have problems, and it doesn't change with pedicle screws. I can tell you that. And fusion is not definitive, like this patient tells you. She had all kinds of surgery, and everyone tells her this is the last time surgery because we fused the scoliosis, and she learned the hard way that she had anterior fusion, she had Harrington rod, she had pedicle screw instrumentation, and a few different things. So let's talk about thoracolumbar scoliosis again, which probably started, VBT for thoracolumbar curve started around 2018, and there are less than 10 published studies. So I have to tell you a little bit about my journey. I performed thoracolumbar scoliosis from 2017, VBT surgery for that, and I operated approximately 250 patients with lumbar scoliosis. So my experience, this was one of my first patients. Young patient, 13-year-old girl, 64 degree, very flexible, and she's still immature. Not in the growth spurt, but still immature. Just go into yourself. What would you do? T4 to L4 fusion, and we hate to do it. I know, I still do fusion, and everyone hates to fuse a kid to L4, and even L3 is not great. So I went for vertebral body tethering, and I was very happy to see my first x-ray, and I thought this is a home run. She's going to continue to grow, and she will have a straight spine without fusion. 1 year later, unfortunately, she had a loss of correction because she broke her tether probably at the bottom level. and now she's at 29 degrees, which is still 60% correction, so still not bad. 60% is what we have with fusion for Linky 5. This is what the big study groups have in average. So experienced surgeons are only able to get a 50-60% correction for Linky 5 curves. At 2 years, she probably had another broken tether higher up, but her curve stayed stable at 31 degrees. And at 4 years, she had another loss of correction, probably more breakages. She's at 35 degrees, so a little bit less than 50% correction. It's probably acceptable, but we would like to have better. I think you agree. We would like to have a better outcome. So this is a sagittal. So we went to the lab and checked, does a double tether technique maybe provide better outcome? And just to make it quick, the double tether technique at least doesn't reduce motion more than a single tether technique does. So it's not stiffer by adding a double tether. So we started a double tether technique, and we looked at our lumbar curves, and we found that breakages still occur. 9 out of 10 patients at 2 years have signs for a broken tether, at least at one level. Now I'm going to show you this data, and it shows you that the average preoperative curve is around 60 degree. It was corrected down to 20 degree and ended up at 2 years at 30 degrees, so 50% correction. Despite tether breakage, 50% correction is okay, but it's not perfect, but it's better than pre-op. And this is one patient that I show you started at 41 degrees and at 2 years had a broken tether, but her lumbar curve only measures 8 degrees. So yes, broken tether, but still a successful outcome. I just want to make sure that you understand tether breakage is not failure. And the outcomes are getting better. You know, we have a learning curve. We have better tethers. This is all published, and right now we use the 2.5 millimeter tether, so even the implant got better. And now we're at a 71% correction rate, and we have a success rate of 100%, which means 2 years after surgery, 100% of patients have less than 30 degree curve. And this is one example. If you have a good outcome, 48 degree straight spine after 2 years, flexible spine. So this patient does not have scoliosis anymore, but also does not have a fused spine. And then if you look into the details, you also see the changes in the bone and the growth modulation. So what's being investigated right now for the future? Something that I really like is the apical fusion, which we started 5 years ago. That means if you have a very rigid and wedged disc at the apex, why not combine fusion with tethering, as you can see here? And it shows you after 1 year, we have a very nice outcome at the apex and no loss of correction because it's fused. And here's the sagittal. We did publish biomechanical data and we did publish clinical data, and just with respect to the remaining time that I have, I can make it very short. Breakage rate was reduced by 90%, at least the early term breakage rate within the first year. And we do have biomechanical explanation because there's less stress on the tether, even at the adjacent levels. And I want to show you a case example. Very big lumbar curve. Just go into yourself. This is a T4 to L4 fusion, but patient is still immature. The problem is has a very rigid spine. So what we did is we combined with an apical fusion, and you see the 3-year post-op outcome, and the patient has a 1-level fusion instead of a 12-level fusion, but still has a very good radiographic outcome. So there is also a chance for bigger curves like here, 73 degree, not a candidate for VBT, but we did a 2-level apical fusion instead of a 12-level fusion. It's not a perfect straight spine, but at 2 years, the patient has a lumbar curve of 18 degrees. So do you want to have a perfect straight spine, but you are fused? Or do you accept some curve, but are flexible? But actually, to be true, even with a fusion, we don't have a 100% correction rate. Good surgeons probably are somewhere around 80%. And this is the magnification. You see from 52 degree apical corp angle, she was reduced to 19 degrees, and that stayed stable. Another interesting surgery is actually the hybrid surgery. So hybrid surgery means combining posterior spinal fusion to lumbar vertebral body tethering. So look at this case. This is a 13-year-old patient. RISA-1 centers for 100-degree thoracic curves and 82-degree lumbar curves. Hypokyphos, actually low Doric thoracic spine, very stiff. So this is not a candidate for VBT, I can tell you that. And it's not a candidate for selective thoracic fusion for several reasons. But look at this. We look at the lumbar spine, which was 82 degrees in prone position, which was reduced after putting the pedicle screws to 57 degrees. After correction of the thoracic curve, it was reduced to 29 degrees. Now it's a candidate for VBT. And when I position the patient in lateral position and put the screws, it's only a 10-degree curve. And when I place the tether, it's 0 degrees. And then you have the perfect outcome here. You have a flexible lumbar spine, a great correction for the thoracic spine, lateral great correction with thoracic kyphosis, but still a flexible lumbar spine. So I will stop here. I can tell you more for hours, but I don't have time anymore. So stay tuned for more, and I thank you very much.
Oh, yeah, thank you, Dr. Trubisky, for excellent talk on vertebral tethering. Any questions from the audience? Yeah, I'm a deformity surgeon, so I'd like to ask a very simple question to you. Yeah, I think that breakage of the vertebral tethering commonly occur at the most distal level. So what's the cause of the breakage commonly occur in most distal level?
Yes, that's a very good question, and we looked at this in detail, and I can confirm that it starts from distal and goes to proximal. So the reason is the stress on the motion segment, because we explanted several broken tethers, and it's not broken at the screw tether interface, which could also be by biomechanical explanation. It's broken at the level of the disc, and we believe it's most because of this is where most of the rotation happens. So breakage, if it happens after skeletal maturity, we found that the curve does not come back, but it should not happen before skeletal maturity. So we need a tether. It doesn't have to hold forever, but maybe 2 or 3 years, and then we should be safe.
Okay.
Dr. Par,
Yeah.
I have a question. I have a question. I have been observing Dr. Higde is one of my mentor, and he now is using this technique as a growth modulation technique as well in patients with significant residual growth. Some of the EOS he is managing with this, and later on he goes for fusion. So, what's your experience about that?
So I have not started doing it for early onset scoliosis, but I have seen great cases from different surgeons. What we know is that the tether holds for 2 or 3 years, but on the other hand, early onset scoliosis patients are very often underweight and have a very low BMI, and that is protective. So in these patients, the tether probably holds for several years. So what's the alternative? You can do some growing rods, and then you have to operate again for sure, or you can try putting a tether. And then it may work, but if it may not work, you do the second surgery like in other cases. But as we don't have data on this, I don't recommend it to everyone. I think it's good that a few specialized surgeons try it and they have to publish their data when they have it, but I would not recommend it to the general surgical population.
Yeah, okay, thank you, Dr. Rubis. And these times of, so as we conclude, APSS is white paper, Masterclass on motion prevention in spine surgery. I think that the key take-home message is that motion preservation should not be pursued simply because motion can be preserved. It should be chosen only when it truly improves patient surgical outcomes. So I think that as a spine surgeon, our responsibility is not to choose between fusion and motion preservation as a competing philosophy, but to choose the right treatment for right patient at the right time. And thank you again to our outstanding faculty members, organizers, and all participants joining us from across the AP regions. It has been my great honor to moderate this session. Thank you very much, and see you next time, our APS online webinar. Again, thank you.
Thank
Thank you
you.
very much.
Thank you,
you
everyone.
all. Thank you
Thank you
all.
so much, Prof. Thanks. Bye.
Thank you.
Thank you, sir.
Bye. Have a great day ahead.
Hello.